and I hope that this stimulates a bit of discussion here. I will ask you to review the chats and to then address, Amrit, maybe you can do that or somebody else, and just to let me know what the questions might be. So thank you very much.
Thank you so much, Dr. Cash. I now request Guru to go through the chat questions and put across the questions.
Yes, Amrit, thank you for that. And good evening, Dr. Richard. I have a couple of questions that have been posted by my colleagues in the chat box, and I've already collated them here for you. So shall I go ahead with the first question that we have here?
Please do. How much time do we have?
We have
45 minutes, yeah.
Okay, so that we're in no rush.
Yes.
I didn't want to leave just a little bit of time, but give us enough time for a discussion.
Sure. Thank you for that. So can I go ahead with that?
Please.
Yes, thank you for that. And I have my first question here from my colleague Sankal. So his query is like, when we look at India, so India being the major part in the rural side, so how do we motivate doctors and the other healthcare staff to go towards the rural for working?
Well, I think there are lots of ways to motivate. First of all, just your profession should be a motivator. Hopefully, people who are in the healing profession will see this as something that is their calling and not simply a way to make as much money as they can. And I think the vast majority of care providers, from physicians on down, that is nurses, ASHAs, and so on, are committed to this. We need to make sure that we provide them with an environment where they can actually function. Nothing more depressing than being trained to do something and then going to a place and not having any equipment available, having health clinics dirty and filthy, no water, no sanitation. It's appalling sometimes when you go out and you visit a number of rural treatment centers and there isn't even a good water supply and no sanitation. And we're trying to convince people that this is something they ought to do. So I think at the first instance, we've got to provide those individuals who are on the front line with what it is that they need. I'm not suggesting an incentive system to a monetary incentive system like you do so many tubal ligations or so many of this and so many of that and you get paid. Those are wrong incentives, incorrect incentives, and have, as you know, led to a certain level of abuse. But there are other incentives. There are promotions. There are recognitions. All of us in your own profession being recognized by government, by others, by the community is a great source of gratification. And so we need to think about that. We need to think about how do we make people want to do something, which in fact, most of them want to do. Otherwise, they would not have entered that particular profession. There are exceptions. I mean, there are obviously people who don't do that. We're seeing that every day. But I think we go to I tend to be a glass half full person, as you can see, not a glass half empty person. Okay? Thank you.
Thank you for that. So continuing with the same, with Sankal. So the second part of his question was related to the patent protection versus the generic medicine. So with regards, when we are comparing it to the developing and the poor countries. So what is your take on that, doctor?
I'm sorry, I don't think I understood the question.
Yes, let me come again. So with regards to the medicines that's being produced, so the patent protection on that. So normally the organizations, they try to have a patent on the medicines. And when we look at the generic medicines, so which are freely available. So what is your take on that part?
Well, there are international laws and regulations and so on. Let me leave that aside. The vast majority of medicines that people need are, frankly, in the generic field right now. And India is the largest producer of generic drugs globally. The big issue here, of course, in India is the quality of those medicines. There have been some recent books which have questioned some of the producers of those. And that's something that the government of India and the Drug Administration must pay attention to. But the vast majority of what people need are freely available. Let's look at the recent recent crisis on COVID. There is a drug called remdesivir. The fact is, it doesn't do very much at all. It costs thousands of dollars, and whether or not the patent is held by the pharmaceutical company, frankly, in my view, doesn't make a damn bit of difference in terms of healthcare that the vast majority of Indians will require. What India really needs is to make sure that there's oxygen available for people who have respiratory problems, that they are put in the bed properly on their belly if they have respiratory problems. But all of these drugs, most of them are of no use, like hydroxychloroquine or various teas or different preparations. Most of them are worthless anyway. And the one that has been shown to have some marginal impact, there may well be issues of patent and so on. I don't think that ultimately that makes very much difference at all. Not to the vast majority of Indian citizens.
Thank you for that. So the next question that I have is from Amit. His query is like, when we look at tuberculosis and corona, both are life-threatening. There are so many people dying due to tuberculosis every year. And now TB, it's also now moved into a drug-resistant disease, which is similar to COVID, wherein there is no vaccination for COVID at this point of time. But people are not scared of TB, but we are much afraid of corona. What could be the possible reason on that?
Well, that's a rather long and complicated question. Let me try to address that as best I can. I co-authored an article with Professor Vikram Patel, who's now who's on our faculty, but presently is with his own group in Goa, Sangha, in the Lancet in early May. And one of our great concerns was, with the whole COVID situation, is that the response to COVID was going to cause far more damage than COVID itself. Okay, that the lockdowns, and all of the impact of that in terms of reduced transport, keeping they were very good at spreading the virus of fear. Fear is also a virus, and people became so fearful that they stopped going to hospitals, even when they had symptoms of tuberculosis. And so referrals for tuberculosis have gone way down. People are not getting the treatment that they got in the past because they don't come to clinic, or it's not being distributed in the community. There will be far more deaths from that, from decreased immunization, from decreased prenatal care, from all of what we call the bread and butter, the basic health needs. There will be far more mortality and morbidity associated with that than will ever be associated with COVID-19. Now, and I think data is already demonstrating that. In Bangladesh, India, and Pakistan, the deaths per million is pretty much the same. Whether you have a severe lockdown, lockdown light, whatever you do, the virus is spreading, but it's not causing the same mortality patterns that you're seeing in Western countries. Not the least of which is because this is a disease that kills older people, people like me, people who are over 60, 65. Well, India is a very young population. Bangladesh is a young population. Pakistan is a young population. And and therefore, the number of people dying from these conditions will be far less per million than in the United States. The last time I looked, India, all three of those countries were 20 to 30 per million. The United States was 440 per million. Okay, that's about a 15-fold difference. So the concern that we had, and your questioner had, is what about these other conditions? Tuberculosis I think people still are aware of it and fear it. The beauty of the BRAC program is that it was community-based. It was active surveillance. Active surveillance means you go out and look for cases. You don't wait for them to come to you. You look for them. You seek them out. And then you can identify them earlier so that the time that they spread the infection is reduced. And you start treatment earlier, and you ensure that treatment continues. Now, one could look at the COVID situation in somewhat the same way, and that is if you can identify an individual early who is certainly sick through contact tracing, you can use probably the most effective tool that you have, which is the use of masks. Masks or face covering, doesn't have to be a mask, it could be a bandana or something across your face, dramatically, in my view, reduces the spread of disease and the severity of disease. You combine that with hand washing, which is not always easy, certainly not easy in the slums of Mumbai or any large city because soap and water is now often not available. But the simple use of masks itself around people who are sick or people who are sick, it will reduce the spread from person to person. It will protect the person who's not sick, and it will reduce the intensity of the infection. That's something that's really doable, is about as cheap as it gets, and should be extensively used, especially in crowded situations in a dwelling or outside, which, as you know, is extremely difficult. You know, in the Dharvi slums, how are you going to keep people away from other people? It's probably next to impossible, but you can help to reduce spread by using facial covering, being outside, and so on. And as you have seen, the outbreak in Dharvi seems to have come down. But again, early identification, directly observed therapy are ways that we can help to reduce the burden of tuberculosis. And we should not allow our response to something else to prevent that from happening. Okay?
Yes, doctor. Thank you. Now, the next question is from Bipin. Doctor, what is your input on telemedicine in rural India? And like, what are the measures the government needs to look into when it's going towards telemedicine?
I'm certainly no expert on this. It's clearly been used more than this outbreak has led to a much more extensive use of telemedicine. Of course, individuals have to be able to use that system. I know that, for example, the Aravind Eye Hospital in Madurai has made great use of telemedicine in terms of diagnosis and so on for a number of years now. So I think it has a possible value to diagnose certain conditions. But I think ultimately, you know, they used to say most people have what most people have. That is, the very common things, I think, still can be dealt with in the community. There are certain conditions, obviously, where getting a telemedicine connection is important. But remember, at the other end, you can diagnose and you can prescribe, but there has to be somebody at the other end of that dialogue who has the medicines and can prescribe. So you could, that's why I suggested that the model for hypertension and diabetes and so on, certainly you could do it, but you have to have somebody at the periphery who can measure blood pressure, who can measure blood sugar, and then convince people that continuing care, because with chronic diseases particularly, we don't cure many things in medicine. We cure a lot of infections, but most other things we don't cure. We create a situation where people can live with what they have or reduce the risk of that. So you can reduce the risk of obesity and diabetes and so on by avoiding sugary drinks, things of that nature. But when somebody gets diabetes, it's a lifelong condition. How do you manage that? How do you get them to change their diet? How do you get them to exercise more? How do you get them to look after themselves? Because the condition itself is not going to be cured. Hypertension is not going to be cured, what you want to do is to make sure that people maintain a blood pressure that is safe, through diet, through exercise, through simple medication. Things should be as simple as possible, to requote Professor Einstein, but not one bit simpler. Okay?